We've covered the fifth biggest obstacle in detail. The fourth biggest obstacle we face in establishing and maintaining a quality standard of care veterinary dental service in our practice is radiographic interpretation. We've got to be able to look at radiographs, quickly evaluate them, make notations in the chart, create treatment decisions, and then initiate those treatment decisions immediately so that patient anesthesia time is minimized. It's best in almost all cases to establish the diagnosis, the treatment, and do the actual treatment in the same anesthetic episode. The reason being is a lot of the resistance to anesthesia is the anesthesia itself, and so it's very difficult sometimes to get clients to agree to have that anxiety instilled upon them again at a short interval in the future when we could have taken care of everything at one visit and alleviated the patient stress of 2 inductions and recoveries and the client stress and the client inconvenience of having them come back for the procedure. And that's a common question in our lectures from the audience. Is that something that we should be doing? Should we be taking our radiographs, making the evaluation, making the treatment recommendations with client education, and then scheduling like our human dentists do and get the patient back at a later time? And my answer to that is no. And if you're doing that, then it can definitely work better the other way. If you're doing that, the chances are you're not efficient in the process from induction to full mouth radiographs to the point where the surgeon or the veterinary dentist or the practitioner that's doing the veterinary dentistry in the practice is getting in to proceed with the procedure. So that time interval between induction and surgery should be at the very most 20 minutes. And maybe in a very large dog, it could be up to 25 minutes. But for our practice, for the small patients, the dogs and cats, it's generally 12 minutes or less. For all of that I just described earlier, at the most 15 minutes or less in almost all cases. 20 minutes in a large dog would be a long time for that to happen. So we want to get to that point so that we're not forced to feel that we need to get that patient back at a later time. That process proceeds systematically the same way every single time, and that way we can get to the point where we're providing that service, and it's much better for the patient, much better for the client, much better for the staff as far as time goes. So in order to do that, we've got to have our process down like we talked about in number 5. We've got to have our doctor able to recognize radiographic pathology quickly, make quick decisions, and then be able to proceed with the treatment accordingly. So let's go through a couple of common scenarios that we see almost every day, and we're going to be covering about, I would say, 85 to 95% of everything that we're going to be seeing without variations in our cat and dog patients with these few examples. So this is a small breed dog, about 6 years of age, that was in a practice adjacent to a practice where we were setting up a specialty practice. And so Annie and I were there. We walked to the practice, which was next door to the building we were setting up in, and asked if we could take full mouth radiographs of this procedure that they were doing when we walked in. And they were more than happy to allow us to do that because they were contemplating getting radiography for the practice. So we interrupted the technician in her cleaning. Annie took full mouth radiographs. Within a couple minutes we were done. We took the doctor with us to another part of the treatment area and sat down and looked at the radiographs.